to the another exciting episode of OptiSphere podcast channel by Opti Consult Me, where we delve into world of eye care, innovation, and future of optometry. Today we have a special guest with us who needs no introduction, Isha Dave. Isha Dave is a leader in optometry practice, and she has an expertise in comprehensive eye care and specialty contact lenses. Along with that, she is a dedicated faculty at Lotus College of Optometry and a visionary founder of Asira, a groundbreaking software in optometry and for eye care professionals. Through this conversation, we are going to understand more about her journey in optometry, eye care, and how she is shaping the future of eye health by innovation, practical learning, transforming eye care with innovation. Isha Dave is paving path for the future of optometry and eye care health in India. So today we are going to have an insightful conversation on practical approach, innovation, and ideas for future optometrists. So we welcome Isha Dave. Welcome, ma'am.
Thank you. Don't call me.
When you hear the term optometry, what is the one word or one thing which comes to your mind quickly?
I mean, that's who I am. It's all I know. Like, a lot of people ask me, like, what do you do? And I say, I'm an optometrist. And then I think to myself that it's literally the only thing I'm good at. Like, I have no other skills, no other skills to that level. You have these people who have their profession and whatnot, and then they're amazing at something else. Like, they're amazing at singing, or they're amazing at like playing an instrument, or they do like martial arts, or they have some incredible hobby that's like a massive part of who they are, which they completely excel at. I don't have any of these things. I'm not good at art. I can't sing, I can dance a little bit, but other than that, I have no other special skills. Like, this is, being an optometrist is a massive part of my identity. Like, that is who I am, and I can confidently say that that is where I excel.
Okay, great. So optometry and Isha go hand in hand.
Oh yeah, definitely.
Okay, so you have been practicing for so long here in Mumbai.
Yeah.
We know that you have come from UK. So how was the transition from having practiced and studied there in UK, and coming back to Mumbai, settling down here, experiencing all ups and downs? So how the journey has been, and what is the motivation of your transformation or transition from your UK practice to India, and what is the difference there and here in India?
So that's a really good question. It's a multifaceted question because there are so many different aspects. So if we start from my personal journey, for example, practicing in the UK is easy. It's easy. The qualification part is very hard. To get onto the register is very hard. There's a lot of difficult, at least when I was there, at least when I was qualifying, which was many years ago, it was very difficult, and then the sense of satisfaction you get from like getting on the register is incredible. Once you've crossed that hurdle, then it's easy. It's easy because you get paid well, and you sort of do your day-to-day job and you do your day-to-day work. And it can also get, unless you make a special effort to go in a particular direction, it can get kind of monotonous, which is what I started finding over there. So 2 years into practicing in the UK, where as an entry-level optometrist, with no specific extra qualifications as such or experience, you really can only do what we call high street practice. So, like where you have an optician and then you have an optometrist in the back who will do all your eye exams and everything. Now, don't get me wrong, optometrists in the UK have much, much more responsibility because they're heavily regulated. They do NHS eye examinations, so they are responsible for taking care of the eye health of patients who are on the NHS. So that's a big one. And they do a lot of co-management with ophthalmologists to
Okay.
reduce the burden, because most tertiary care is on the NHS, which is heavily burdened in the UK.
Okay.
So the optometrists play a massive role in taking some of that burden off the ophthalmologist and doing it within their private practices.
Okay.
So in that sense, it is quite far ahead in India, because you don't see a lot of optometrists doing co-management with ophthalmologists, you know. So in that perspective, I did really enjoy practicing in the UK, and I feel like, and of course the money was great.
Yeah.
You know, as a locum optometrist, you can get paid up to £500 a day, you know,
That's
which is
amazing.
great. So you can work 3 days a week and, you know, have a lot of freedom. But then again, it is the same thing again and again. And you can keep, when you're making a lot of money, you're not motivated to push yourself. You're not motivated to go further.
Yeah.
You know, you kind
You're
of
in the
like,
comfort zone.
you're in the comfort zone because you're making money. So
Yeah.
like, why?
Yeah.
You know, I feel like that really wasn't me. And it was one of the things that made me want to come to India, because I came to India and realized that, okay, people are doing different things here. I have different opportunities.
Okay.
I didn't make any money here. Not for a while. You know, it took a while for me to establish, you know, my practice and my patients here. And it took that was a difficult transition. I almost gave up many times. Many times. I was like, I'm done. I can't do it. I'm going back. But in the end, I decided to stay, and I think it's the best decision I ever made, because like I moved to the UK from India. You know, I was 10 years old when I moved to the UK from India.
Okay.
And I was in the UK for 20 years. It never felt like home. I know I sound British, but if you speak to a lot of my friends, they will tell you that I'm very Indian.
By heart.
Yeah, exactly.
Yeah.
And so 20 years I was in the UK, never felt like home. The second I set foot here, I was back home.
Okay.
You know, so it's home now, and it continues to be home. And I can't imagine, sure, I'll go back to the UK, visit, maybe even work, maybe even, you know, do a little bit of, you know,
work there.
Work-wise.
Yeah.
I still go for conferences and stuff. I still have maintained my GOC registration.
Yes.
So, you know, that's always there, but this is home, you know.
I think it was heart touching for me, you know, as soon as you touch the soil of our country and then we feel that it's home.
Yeah.
Yeah. So two things which I understood from your conversation, for entire UK part, I want to understand more about NSH when you are talking about, and what is co-management in simple terms for our audiences.
Okay, so the NHS is the National Health Service. Okay, so the UK, unlike the US, has healthcare is free. The government covers healthcare, as it should in all countries, okay?
Yes.
It does in India also. People think that it doesn't, but it does. You know, but of course you have to go to government hospitals where you will get government healthcare.
Yes.
So like all government healthcare everywhere, it is not efficient. And it's always going to be difficult because of budgetary restraints and those kind of things. So there is a massive, like I said, there's a massive burden on the NHS because of the huge influx of patients. Now in the UK, the aging population is growing. You know, people wait 2 years to get a cataract surgery done.
In
2
UK,
years.
In UK.
Yeah, there'll be a waiting list of 2 years to get a cataract surgery done. You know, that's once it's decided that there is a cataract that is ready for extraction. Of course, there's a triage system. So depending on how much of an urgency it is, you will get bumped up the list. But yeah, an average waiting time for cataract surgery can be anything between 9 months to 2 years, which is unheard of here. Here, you'll get it done in a week.
Yes.
You know?
Yeah, we are we can't wait.
Yeah, exactly. So the burden is very high. Now, you have a high number of patients with macular degeneration. You have a high number of cataract patients. You have a high number of glaucoma patients. Now, some of these things like glaucoma and ARMD, they need to be monitored.
Yeah.
And what will typically happen is the patient would go to the hospital, even keratoconus, for example. The patient will go to the hospital, spend half a day waiting in the waiting room to spend 15 minutes with a consultant.
Oh.
So, and then that's just for the consultant to say, yeah, you're fine, you know? So a lot of that responsibility has been shifted to the optometrist, where you have to do a little bit of studying and get a special qualification, and then you can co-manage. So, for example, if you co-manage glaucoma, then all the glaucoma patients from your local hospital will come to your practice for their routine examinations, and they would only go back to the ophthalmologist if you decided they need to go back. So if you're seeing progression, you know, so, and then of course that applies in diabetic retinopathy, that applies in cataracts and macular degeneration. So that's what I mean by co-management.
Oh, that's amazing. So there is a difference, definitely, you know, if you come to India, and we see so many patients in the primary eye care practices and government officials. There are so many campaigns going on for cataract. There's a lot of you know, treatable conditions what we have in our country, and still there is a burden.
Yeah.
So, but we have not regularized optometry as such, as
Yeah.
a profession.
It's not regulated.
So
Yeah.
what is the basic difference? What we as a you know, optometrist have found out here, and how can we fill in that gap and do up for our you know, budding optometrists, for us who are practitioners? How do you define our role being not regulated, but still we want to have a quality practice services and provide for the patients here?
One of my professors at university, my contact lens professor who has now retired, was Judith Morris. And she taught me everything I know about contact lenses. And I remember when she had come to India once for something, and you know, we were talking, and she said, she made a very, very valid point. She said it's education, then regulation, then legislation.
Okay.
You know, so it starts with education. So we need to standardize education to begin with. We need to standardize. So, for example, without sounding biased to my college, which of course I totally am, you know, there's a lot of practitioners, a lot of doctors, ophthalmologists, private practitioners who will only, including myself, who will only hire optoms from Lotus, right? Only because of the standard of those optoms that come in. We don't have to spend any time training them. You know, they know the basics. All we need to do is train them on how our practices are run and how we do things in our practice, you know. Sometimes, you know, optometrists from other colleges may not satisfy that same standard, even though the syllabus is the same.
Yes.
You know, we have so many optometry colleges in India. So first of all, there needs to be a standard at the education level, at the college level. Then one thing that we have in the UK, which I think we need to do here as well, is something called professional qualifying exams.
Okay. Yeah.
Which is run by an external body. So in the UK, it's the College of Optometrists that runs these exams. So in India, for example, an equivalent to the College of Optometrists would be ASCO, the Association of Schools and Colleges of Optometrists, who would act as a, you know, examining body, who will carry out the exams, who will create the examination centers. So you're not necessarily doing it within your college. You may have to go to an external examination center, or maybe an external examiner, which is appointed by ASCO, will come and do your exam. You know, so and that has to be standardized, you know, so the exam is standard for everybody.
Everybody passing from the bachelor's, like after completing
from the bachelor's, after the internship.
Before practicing, they should undergo a bridging course.
Not a course,
No,
an exam.
It's an intern, like
it's an exam.
Entry-level exam for practicing.
Yeah, a professional qualifying exam.
Yeah.
You know, and now in the UK, we had to pass that professional qualifying exam to get onto the register.
Yeah.
And that's then, of course, we need a regulatory body.
Yes.
So now in India, I believe it's going to be a bit different, because we have got a regulatory body in place nationally after the NCAHP Act.
Yes.
Okay, from 2021. So now, of course, we've got all, in the UK, it's different. UK is one country. Okay. India is like so many different states.
Yes.
Which, as far as I know, as far as I can understand, is as much as we're one country culturally,
We are very different.
we're all the states are very
Yeah.
different, you know. We're huge, we're vast. So of course, each state will have to have its own council and council members, and then so that I imagine would be eventually will become the regulatory bodies for the state, which is under the NCAHP umbrella.
That
Right, so I think
long way to go.
that it's a while to go, but I think we're definitely headed in the right direction. I think there's a lot of people putting a lot of work in, you know, and I have to commend those people. I don't need to name any names. They all know who they are, but I have to commend them for all the hard work they're putting in.
Yes, yes.
You know, not just in Maharashtra, but across the country.
Agree.
To create these state councils. So I think it's great. We're moving in the right direction for sure.
Yeah, that's true that we are moving, but we are taking baby steps, I would say.
You know, when, you know, the thing is, when an outsider comes to your country and comes and, you know, sets up camp for 400 years and takes away everything, so that you have to start from scratch.
Yeah.
You know, strips your economy, strips your culture, takes away everything, and then imposes their culture. You have to start from scratch, and that's where we are. Unfortunately, you know, we could have been way ahead.
Way ahead, yes, agree.
You know, we would have been way ahead had the British Raj not happened.
Okay.
You know, so we could have been. But now this is where we are, and I think the kind of progress that India has made in only 74 years now.
76, yeah.
76 years, is
tremendous.
Tremendous.
Yes. We are evolving, and there's a lot of science, technology, even in all aspects, all areas we are growing. So that's for the fact that yes, we have innovative minds here.
Yes,
creative people.
We do.
Yes.
We just don't have processes. See, this is what the West is really good at. SOPs.
Yes.
Standard operating procedures. Right? We're not. We're kind of a little bit haphazard.
Yeah.
The West is really good at SOPs and making people follow standard operating procedures. You know, but
that is a plus point, I guess, because we can experiment, we can try.
We can. I mean, we do need to be, just generally, I think we do need to be a bit more organized. But of course, when you have a population of 1.5 billion, that also becomes a challenge. You know, and then a hugely diverse population. I can't see, maybe other than like Russia and China, I can't see any other country in the world that has such a diverse population. Yeah. You know, it's massively diverse.
And that's actually an opportunity and a strength.
Correct.
Yeah, for us. Now you have built, after coming from UK, you know, you've built such a strong, comprehensive eye care practice, which I see unique. I haven't seen optometrist with such a strong, comprehensive practice, you know, built in through the years. Would you suggest, like, what is your secret sauce, you know, secret mantra of this? How do you actually comprehend with comprehensive eye care? What advices you do give to our young optometrists and the current generation, and how have your practice evolved in these years? So what is your secret sauce to it?
I mean, first of all, my advice to people is you have all the skills you've been taught.
Yes.
So just start, you know. It takes a bit of planning. Now, if you're in a privileged position where, you know, you have some generational business, you know, you have a family business, which you can develop, that's a great opportunity, you know, so definitely you can help develop that. You know, that's something that you already have a platform, you know. For people who are starting from scratch, which I know there's a lot of people who do, you know, it does take a a bit of planning and then a bit of pushing, and it's difficult. It's hard because, you know, you sort of feel very disheartened at the beginning and you feel like you don't know what you're doing wrong, but you just have to have patience and persevere. That's it.
So what do you suggest after completing a bachelor's and somebody who doesn't have a background and wants to start a practice? Should we directly jump into opening our own setup?
No
Or-
way.
Okay.
No chance. That would be the worst decision.
Okay.
How would you know what to do?
Correct.
Right? If you have a family business, your family will be able to guide you, and then you
need mentorship.
You need mentorship. You
Mhm.
need some experience.
Mhm.
You know, so you have to go and work for someone.
Mhm.
Definitely for 2-3 years.
Yeah.
You know, 2-3 years at least. I mean, so with me, I did work
Yeah.
for 2-3 years for other people, and then come here, and I also had some mentorship when I came here.
Yes.
You know, so I was in that privileged position.
Yes. At
You know, but
least minimum 3-4 years or
for sure, definitely do not jump into starting your own business straight out. You need experience. Experience counts
that's
for a
what
lot.
for so many of us we fail because we try to get into opening our own setup immediately after graduating. And something I would also suggest that maybe you can correct me, that after, even if you have your own setup, your own businesses, your own platform,
Mhm.
you should work for somebody.
I agree.
Yeah.
Because there's always things that they might have done, they might do differently, which you could incorporate into your business.
Right.
You can always learn from other people, you know, and it's there's always something you can learn from the good things they do. You can also learn from their mistakes.
Yeah.
You can also see, okay, I don't know if I agree with this. This is not how I would do it.
You bring in a lot of ideas when you work
Exactly.
at different places.
100%. I agree.
Yeah. So that is one thing I would, we would take it from this, that always work before you start your own practice.
100%. I completely agree with that.
So what we should do, we should focus, like you have your specialty contact lens. Like what we know about Isha is like, when Isha comes, it's like contact lenses.
That's
Correct?
because I taught you contact lenses.
Maybe. Yeah, could be. That would be one of the factors.
That wasn't my intention. That was
Okay.
an accident.
Okay.
Right? That was never, like, when I graduated, it was never my intention to
Okay. To
do
specialty.
to do any kind of advanced contact lens. It was never my intention.
Okay.
I was just good at it. I understood it. I understand fluorescein patterns.
Yes.
That's it. That's all it is. I just understood.
Fluorescent is about contact, the rigid gas permeable lenses, right?
Yeah.
Yeah.
Yeah. So that's it. I mean, with contact, I mean, the main advice I can give to people who want to practice contact lenses, and it's so simple, and people think it's so complicated, and it's not. It's so simple. If you understand how the tear film behaves between the cornea and the back surface of the lens, you're done.
Yeah.
That's all rigid contact lenses, whether it's corneal, scleral, whatever.
Yeah.
If you understand that, then it's done. The only thing where I would think is a bit more challenging in contact lenses, which is why I love it and have decided to like push forward with it, is orthokeratology.
Orthokeratology.
Yeah. I feel like that is a bit more challenging.
So my question here is like, we should focus more on specialty
No.
practices or comprehensive?
No.
You
Why?
suggest comprehensive.
I mean, start somewhere, you know, like you can't, like, so I must have, before I did my first, my first, let's say, rose keratoconus fit, I must have done like 500 RGP fits, like normal ones.
Before that.
Yeah, like normal ones.
Yes.
You know, so, before I started soft lenses, I mean, you should be doing
the basic clear, like the basic ones first.
Yeah. So comprehensive eye test. Everybody knows how to take a history, do some basic BV tests, do a refraction, look at the slit lamp, do a slit lamp evaluation, do some ophthalmoscopy.
Yeah.
That's it. Everybody knows that. And how long is that going to take? 20 minutes?
Minimum.
Then charge your fees.
Correct.
For the 20 minutes you took.
Yeah.
You know,
can we charge our fees like for basic refraction?
Sure. I mean, I don't think that you should. I think that if a patient is sitting in your chair, why stop at refraction? They're sitting there. You've got them in your chair. The biggest challenge is getting them in your chair.
Yeah.
Once they're in your chair, do whatever you want. You know, why are you going to stop at refraction?
Yeah, and I also feel that many of our patients,
Mm-hmm.
they don't go to a eye doctor or
Mhm.
like the ophthalmologist in the hospital directly. They first will come to the primary eye care specialist or a,
That's why we're called primary eye care.
yeah, so they will come here. So
Mm.
if we are not able to identify them at the primary level, like for glaucoma, if we have not checked the IOP, if we have not done the primary evaluation and left them at refraction, then I think we are losing out a lot of we are missing out a lot of patients of these categories, and maybe we can prevent further worsening
Yeah,
of the
I mean,
condition.
you're being negligent.
Yeah,
I'll be very straightforward. You're being negligent.
if you are not identifying
Yeah,
cases.
I mean, then why did you do a 4-year degree?
Hmm.
You know? Well, it's very interesting. I did a talk, I think last year,
Mm-hmm.
with OCI, and the talk was, are you an optometrist or a glorified optician? So and we had a
Can you
long
put some light
discussion
on that?
about
A brief,
that.
brief
We had a
about
long,
it.
and I had 3 wonderful young optometrists
Yeah.
who do comprehensive eye care on the sort of online talk with us, and it was just like a panel discussion.
Okay.
And I did I was the host, like you
Okay.
are today. I was in your chair, and I did like a rapid fire, and I was asking them a bunch of questions,
Mhm.
and what separates a glorified optician from an optometrist. So if you like Neha, you have all the skills in the world, right?
Mhm.
You know everything, you know how to do everything, and yet you'll sit in your shop and do refraction after refraction. I'm not saying this is what you do, I'm giving an example.
Yeah.
You'll sit in your shop and do refraction after refraction, and just sit and sell glasses, and you're making money. Same thing with my £500 a day locum.
Yeah.
I'm sitting there doing routine eye examination after routine eye examination, and I'm making money, so I'm good, I'm comfortable. So then do we need to push ourselves further? You know, I think we should.
Yeah.
I think we should, because that's what you studied for.
Yes.
You know, why can't you make money and be better?
Correct.
Why can't you make money on your glasses and consultation fees?
Correct.
You know,
So
why
it's not
can't people
about
come to you for their spectacles, for their contact lenses, and
a
for like a
comprehensive.
good eye test?
Yes. So it takes me to the history of or the current situation of optometry and eye care what we have in India. The demand is so much, and we don't have supplies.
Mm-hmm.
And if these optometrists and eye care, the basic providers, if we club with our ophthalmologists and co-manage the conditions, we can be more faster and treating, and we could avoid a lot of conditions, like for example I would say glaucoma. Glaucoma is not detected with symptoms. Patients do not come with symptoms
Correct.
until unless they get checked, just like a dental checkup. Until unless you don't get a toothache, you don't go to the dentist. So similarly with the eye, the Indian people, like particularly which I've seen, they do not go to the doctor until and unless they have some problem.
Something wrong.
So
Yeah.
वो चश्मा बनाने के लिए चले जाएंगे. But for getting a IOP check or for getting a comprehensive eye checkup, they wouldn't go to an ophthal, to a big hospital, because one of the factor is they get scared, or they don't want to talk about it.
Long waiting times.
Long waiting time. So it is better we actually upgrade ourselves.
So this is not so much about co-management. Co-management would still be the next step.
Okay.
We're still on step 1,
Okay.
where we need to become better at screening. Primary eye care practitioners,
Yes.
whether it's a GP, whether it's an optom, whether it's a pharmacist even, we need to be better at that step. We need to be better at screening.
Yeah.
So we should be screening for cataracts. We should be screening for glaucoma.
Yeah.
We should be screening. So basic screening is what? Just have a look at the retina. Have a look at the lens. Check IOP.
Agree.
So this is basic screening. Do some basic BV tests. We're talking about basic stuff. You don't need any extra equipment. You don't need any fancy equipment.
Yeah, there's no investment.
There's no extra investment. You have everything already.
Yeah.
So but all you need to do is do. So I don't know if that's a confidence thing. I don't know if that's a I can't be bothered thing. I don't know if it's a I don't care thing. I don't know. I couldn't tell you, Or it could just be I'm comfortable, I don't wish to try harder.
Yeah.
You know, it could be that, I don't know. You know, a lot of people are very comfortable where they are, you know, and
eventually it becomes that ways because everybody is following a certain doing the same thing. We are also doing the same thing.
correct.
Why the person has to come to me for an eye check? I should be different, right?
Yeah,
Yeah.
exactly.
Yeah.
But that's exactly it. Like, if you're doing the same thing as everyone else, you're not really going to stand out, you know?
Yes.
So there has to be something special about you, something
Yeah.
which differentiates you from the others.
So, which I take away from this conversation here right now, that we should not only focus on speciality, because what I've seen here
Yeah.
is many of us get into speciality and forget that what we've already, the basics, what you're saying.
Look, I'll be, even in my practice, you
Yeah.
keep saying how unique, and I want to make this very, very clear, right? People think that, okay, because I'm an expert in certain areas, that's all I see. That is not true at all. 80% of my patients are regular patients who come for routine eye examinations or your usual.
Yeah.
You know, it's the 20% that come for whether it's the specialty contact lens, whether it's the myopia management, whether it's the vision therapy, glaucoma screening, whatever it might be, that's 20%.
Correct.
80%, my bread and butter is my routine eye examinations.
So I think it is very important to understand that specialty cases are very few.
It's few. It's
Yes.
not that many. It's really not that many.
Mm.
You cannot survive on only being a specialty practice.
Yeah.
You absolutely cannot.
Mhm.
You know, you have to be able to do normal
Everything.
eye
I
tests.
think
Yeah.
basic, you need to start with basic, and if required, you have to have your specialty as well. So
Yeah,
upgrade yourself.
Yeah, upgrade yourself when you're ready to. You
Correct,
know, when you
yeah.
feel that, okay, this is something I'd like to pursue. This is something I have a passion for. Sure, you can
Right.
do that.
Yeah. So now that we know that you have a very good comprehensive practice, now coming to innovation and technology. So how do you club this cutting edge technology and innovations in your current practice? Secondly, Asira is making waves in the market. So
That's nice to hear.
yeah. So tell us something about it.
Okay, so where are we at with Asira right now? So we very recently launched the app for opticians.
Okay, great.
So Asira now so we've now divided up into two products. One is clinical, which is the software, and the other one is retail,
Okay.
which is the app. Okay,
Yeah.
because there are a lot of opticians out there, you know, and they don't call themselves optometrists.
Yeah.
They call themselves opticians, and that's
Yeah.
what they do. They hire optometrists to do their refractions and whatnot, but they are opticians, you know, and there's a huge number of them. And we definitely saw that a lot of them were still using diaries and, you know, pieces of paper and files and notes and stuff to maintain their
Yeah.
customer data, you know, because when I say retail, it's not like an H&M, who, by the way, those guys also retain customer data. If you notice, they always take your phone number.
Yes, yes.
Ma'am, I need your phone number and name.
Yeah.
No, you don't. But anyway, they also take your data. But with opticians, more so because they're offering a customized service, right? Like spectacles are all customized.
Yes.
So, of course, they need your information. They need to know, you know, what they dispensed, how much the customer paid when they dispense. So it just helps them organize a little bit better, have quicker access to their patient data, have better communication, patient customer, have better communications with their customers, and, you know, those kind of things. So I said, why should we just help the clinical side? Let's do something for opticians as well. Yeah. So that's going quite well. We've got a lot of good responses to that.
It is quicker and it is application based, so it is voice.
Yeah, everybody has a phone, you know. Most people don't necessarily sit with a laptop, you know, or a computer, but everybody will have a phone or a tablet. Correct. For sure, you know. So that's something that's really nice. With the software, we are sort of working on. So what I've realized, and what I was having a chat with some of my colleagues from the UK recently. We were talking about globally how the world is becoming very legislative, you know, so you end up spending a lot of money, especially in the West. they end up spending a lot of money on legislation.
Yeah.
Because they keep getting sued. Okay.
Yeah.
Now, why do you keep getting sued? Now, you can keep getting sued and it may or may not be your fault. Okay. What is the one thing that protects you is your documentation.
Mm-hmm.
You know, so number one, when it came to Asira from the clinical side, I realized the importance of documentation.
Yes.
I was always maintaining clinical records, written records,
Yes.
which are a pain. You know, I don't need to go into that.
Yeah,
I'm sure,
your paper can get lost and
all of the
damaged. Yeah.
all the rest of it.
Yes.
So this is better, and then of course it's cloud based, so it will not, even if your device dies, you're fine.
It gets saved.
It gets saved. You can just log in from somewhere else. So there's that. So that's one aspect of it. Of course, just making it easier and better documentation and
data saving.
Yeah. So now the next step for us is to think, now how can we make this better? How can we make it better for the profession?
Eye care professionals.
Eye care profession. So the reason people get the reason there is so much legislation is just because a lot of the times, and I'm not just talking about India, everywhere, the practitioners just mismanage the patient. Mismanage as in, I'm not talking about managing patient data, like managing their records. I'm talking about managing the actual patients. They've done the eye test. They've looked at the signs and the symptoms and, all the rest of it. And they've found either they've misdiagnosed or they've missed a few tests. Or they've not referred when they should have referred. They've not taken the next steps that they should have taken, which has resulted in the patient either getting something like glaucoma or, or their glaucoma being missed or, a retinal detachment happening or getting worse, somebody losing their sight. And even something small like, somebody mismanaging their contact lens wear, getting a microbial keratitis. Even these are all things that come from mismanagement of the patient, which ultimately is the responsibility of the practitioner, So how do we avoid that? So in Asira, the plan is to try and not just use it as a practice management software, but also we're starting to build tools, and we're going to try and incorporate things like machine learning and eventually AI. I don't think AI is quite there yet, but we're going to try and incorporate algorithms and machine learning to create a system that can help you manage your patients better. And I say clinically manage your patients better. So you have better, which will help you make better clinical decisions.
Great.
And I think that is the way forward. Because it is, especially if you're junior, if you've just started out, it's very daunting. And we've been there. It's very daunting when you have a patient in front of you and you're just scared. You're like, what do I do next?
Yes.
So that's where we want to move forward and, help with that.
I think that innovation we really needed.
Yeah.
Yes. So software for optometrists. Okay.
Not just optometrists, just clinicians, just anyone in eye care, even if it's a junior ophthalmologist.
Yeah.
They're also the ones that get litigated the most,
Yes. I think it works for everyone.
For everyone, yeah.
That's great. So coming to, questions on, there are some of our viewers who were seeing our podcast and they had questions on their eye care myths. So what is the biggest myth what you have heard till date and that drives you crazy?
Myths from where?
Eye care myth from your patients.
From patients.
Yeah.
So probably the one that drives me the most insane is that children are too young to wear contact lenses. Like that one drives me nuts because we all know that's not true.
Yeah.
It's not true at all. And there are certain places that will refuse to fit contact lenses in children, and that's where the myths come from. Is just because you don't have the confidence to fit contact lenses for children, doesn't mean that it can't be done. Of course we fit contact lenses for children. So this is one of many. There are of course many, but this is the one that drives me the most.
I totally
nuts.
agree that a 14-year-old child, like he's able to do everything else but can't wear contact lenses. you know, I cannot give my child, he's just 14-year-old. I said, if he can eat with his own hand, he can brush his teeth, he can wear contact lenses.
Exactly.
It is as simple.
Exactly. It's as simple as that. Yeah.
It's like a basic thing.
Yeah.
But yes, so for all our practitioners, we would say that, contact lens for children is possible. And if treated, if, what we say, teached well, taught them well.
Counseled well. It's all about counseling.
Counseling,
So if you counsel them well, and children actually make the best patients. You know why? Because they blindly follow your instructions.
Obedient.
They don't question you. Adults think they know better.
Yeah.
And then with things like Dr. Google now, where it drives me nuts, where people come in and tell me, I actually had a patient.
Patient is always right.
No, they're not. They're not always right. In fact, most of the times they're wrong.
But we have to agree to
it's just about the approach, isn't it?
Yes.
I think it is important to tell patients when they're wrong.
Yeah, in a subtle way.
But the one thing that I used to see a lot in the UK, which probably when I used to do glaucoma co-management, patients come in, so how are you doing? Have you been using your drops? Nope. Why'd you stop? Because I'm fine.
Yeah.
So that's a difficult one.
Yeah.
That's a difficult one because they're asymptomatic. Why do I need these drops? I'm fine.
Agree.
So those communications can be difficult to explain. You also have to be very true to yourself and know what your strengths and what your weaknesses are.
And then maybe when you're doing a comprehensive practice and you are not good at a particular subject, please refer.
Yes,
refer to a specialist.
Stay within your scope of practice.
Don't keep a trial and error and experimenting things.
No chance. I'm not going to do this.
Yeah.
This is not my forte. I have lots of colleagues who are very good at this.
Yeah.
Refer.
Yes. So if
refer.
you know low vision, do low vision, contact lenses, refer.
Exactly. I agree. I agree with you completely.
Yeah.
But the counseling
part is very important.
So sometimes, yes, you get the most ridiculous patients.
You have to spend
who
time.
will say the most ridiculous things, who will drive you nuts.
Yeah.
And then you get patients who are, legitimately in a very difficult pace. Post-LASIK ectasia is one of the hardest things to deal with. That's very heartbraking,
Have you seen cases?
Many.
Okay.
Why do you think I didn't do it? After seeing those cases, I'm like, nope, I'm not. I'm good with forget contact lenses. I'm good with my glasses. I have the option of contact lenses. I am not doing that because that scares you.
Yeah.
You're like, sometimes it's like, too much, and you think, no.
So coming to, in your practice, you must be seeing a lot of patients with digital eye strain.
Yeah.
Is it?
Who doesn't?
Yeah. So is it for real? Like one of the comments I had got from a viewer.
Yeah.
That what is digital eye strain? Like you said, there are difficult patients. They're like, this is actually not a true thing. It's a myth.
So, I would agree I don't think it's a myth at all.
Yeah.
But I think it may be overdiagnosed.
Okay.
In certain cases.
Okay.
Okay. I think sometimes when there's nothing else left to blame, let's blame it on the screen.
Okay.
So I think that I certainly don't think it's a myth. I certainly think it does affect
the eye.
A lot of people.
So screen time does affect.
Of course, I do believe it does. I mean, I can't tolerate, personally, I can't tolerate being on a screen
for long hours.
For long hours. I'm also perimenopausal and I have dry eyes and all that nonsense,
Yes.
So that's me, and I'm not accustomed.
So your dry eye is also linked to other conditions in your body.
Of course.
Not only related to your screen time.
Of course.
Screen time adds to it.
Of course. Right? Exactly. So it's a multifaceted thing, isn't it? You can't just blame everything on the screen.
Yeah.
On the flip side of that, you have people who probably are suffering from digital eye strain, but don't know it because this is just all they know. So for example, like my partner, he is a software engineer, product designer, right? And I see him at the end of his days, his eyes are puffy, his eyes are red, he's doing this, he's like watering,
literally,
all the rest. I'm fine. No, I'm fine. I'm like, aren't you tired? Don't your eyes hurt? No, I'm fine.
Yeah.
I know he's got digital eye strain. I can see it.
Yes.
But no, I'm fine. So this is what I'm saying. You know, there's I think
People
it
who have
definitely-
it, they will not talk about it much.
or they may not even know
realize,
about it.
yes.
You know, they may not even know about it. And
And sometimes it is more painful also for people in the IT profession for long hours, like 12 hours on screen. It's bad.
but it's all they know. Imagine this is what you've done since you're 19 years old.
Yeah.
Your eyes change as you get older. When I was in my 20s, I could wear lenses for 18, 19 hours a day, no problem.
Yeah.
First thing in the morning, wake up, put them in, wear them all day, then go out, come back at 2 o'clock in the morning, same pair is still in, sleep, wake up, put them in again. And it was fine. Now, I'll be lucky if I get 5 hours.
Yeah.
Even if as much as I do the warm compression and I take the omega-3. And let's be realistic, you know, it is a thing.
Age is a thing.
It's a thing.
So next question comes in. What is the nutrition we should take it for eye health, like for general awareness? What is your take on the nutrition side?
It's everything.
Okay.
I believe that nutrition is everything.
Okay.
You know, I'm not a nutritionist. I can only advise regarding nutrition with eye health, but I believe that, and don't get me wrong, I'm sitting here saying all of this. I don't follow half of it. You know, I'll be very honest, but I do believe that everything could be better for me if I did follow half of
correct
it.
way,
The
discipline,
correct way.
eating.
Look, sometimes it's not practical, but I do believe that nutrition is everything.
So what do you suggest to our viewers?
In terms of
eye care and
how to
nutrition?
treat how to advise their patients well, it depends from patient to patient, isn't it?
Yeah.
So what I found is omega-3 is a game changer for women over the age of 35.
Okay, great.
Who want to wear contact lenses.
Yes.
You know, it's a game changer. So that's definitely something that I advise,
Yeah.
you know. And then just non-processed food.
Yeah, outside food should be not there.
Non-processed,
food.
exactly.
Yeah.
Even if it's from outside, but it's fresh food, it's okay.
Okay.
You know, I mean, that's my advice. But and you know, I wish that my diet was better. Like, I'm not gonna lie. I mean, let's be honest.
Being in Mumbai with hustle bustle, it becomes very difficult to take care of the
with
diet.
Swiggy and Zomato at your fingertips, you know, it's just easy.
It happens with us.
It's just easy.
And I stop having the Swiggy and Zomato and then have home cooked food. That would actually change a lot of things.
So during COVID, I was in the best shape of my life.
Yeah.
With everything, with my eyes, my skin, my just general function.
Yeah.
You know, everything. I was in the best shape of my life because I wasn't eating out. I was making food at home.
Yes.
Every single day I was eating just home food.
Home food is
And
very important.
That's it.
Yes.
I wasn't doing anything different other than eating home food.
Yeah.
And I didn't have as much stress because I wasn't going to work. So stress plays a big role as well.
Agreed. So taking care of your, mental health
Yeah.
and overall well-being is very important.
For sure.
Yes. So next, we come towards the end of our podcast now. So it was lovely talking to you.
It's always lovely talking to you.
Yeah.
We should just do this and have coffee.
Yeah.
You know?
Definitely we should. So
It's long overdue.
Yeah. So it was lovely, having, I think we should have more conversations and more about your eye care practice. But I would want to ask you, coming back to optometry, where you see optometry in 10 years in India?
Ahead, for sure, moving forward.
Yeah.
Because the next generation, the younger lot, do seem to be more clinically inclined.
Mm-hmm.
I've noticed.
Mm-hmm.
You know, they do want to, given the opportunity and the encouragement, they will do more clinical eye examinations, more comprehensive eye examinations.
The future generation.
The future generation.
And what is one advice, if you have to go back in time, one advice you will give to your younger self?
We pay more attention in optics.
Yeah.
In the
dispensing optics, yeah.
No, in optics,
all
like your ray
physical optics
diagrams and you know,
yeah.
because I didn't realize how much I would use it
later on in life.
later, like now.
Yes,
you know?
yes. So this is a very great advice for all our optometrists, that first year of optometry is very important. Actually, what we do is like keep figuring out what we are doing.
Yeah.
And then we forget the basic
Exactly.
foundation.
Yeah, definitely that.
So take care of your first year. aspirants and current first year students. Now we are going to the exciting segment of our podcast, which is a rapid fire for you.
Okay, I'm nervous. Right, let me get ready for this.
You win an hamper.
Oh, I do. Yay.
Yes.
Fun.
Okay, so one tool, one gadget which you cannot live without in your clinic.
Slit lamp.
Oh, great. Okay, 3 books every optometrist should read.
Kansky.
Okay.
Ophthalmic Lenses by Mo Lee.
Wow.
And The Contact Lens Manual by Judith Morris.
Great. Next question. So, if not optometry, what you would be?
I don't know. I really don't know. Like I said, it's a very big part of my identity. But I'm thinking maybe some kind of psychology related. Because I'm good with people. I feel like I'm a people.
One tool which all optometrists, like if I have to buy an instrument, with one tool, what will you suggest to all optometrists to purchase?
Slit lamp.
In their practicing year, like in their college time.
Retinoscope, ophthalmoscope. We make them do it anyway.
Yeah, in
trial
one
frame.
particular, trial frame, and we should have our own retinoscope and ophthalmoscope.
Ophthalmoscope. People think that it's not necessary, but it is. The ophthalmoscope is a fantastic tool. You can do so much with it. And I still use the same retinoscope and ophthalmoscope that I was using when I graduated.
Yeah.
So that I bought when I was at university, the same ones in my practice today. So
okay. So final one. Thank you for having a conversation and being part of OptiSphere podcast.
Always my pleasure.
We would want you to give a small message to all optometrists on the World Optometry Day.
Oh, right. That's on Sunday.
That's on Sunday.
Course.
Yes.
Okay. So, if you're students, optometry is hard, but it's also fun. If you're new optometrists, build a network. Start building your network. And if you're senior optometrists, guide the younger ones. And whatever you do, have lots of passion. Just do it with passion.
Okay. Thank you so much, Isha, for being here and being so honest with your answers. This is lovely for our audience. So for all of you, for all you viewers listening to us, please subscribe to our channel and stay tuned for upcoming podcasts. Thank you.
Thank you, Neha.